We are going to discuss the topic of contraception in detail, and here in this presentation I will discuss with you the different types of contraception, their mechanism of actions, and the different important questions related to the exam. And also I will discuss the emergency contraception and different types of sterilization as well as intrauterine devices. Basically, I have made this presentation from FSRH guidelines about the contraception. There are several guidelines about contraception. Those are FSRH guidelines. We have different guidelines for contraceptive pills, different for the emergency pills, for IUCDs, for sterilization, and different for different methods. We have different guidelines. Okay, but I have tried to compile few important points from those guidelines. Also, I have taken some evidence, some references from the TOG article, especially about the intrauterine contraception. We have a TOG article that was published in September 2020, and I have taken reference from that as well. Okay, so let us start our presentation. Now, this table just shows the types of different methods of contraception. We may have the natural family planning methods like fertility awareness method. By the natural family planning or fertility awareness methods mean we don't use the specific hormonal or specific method of contraception which is available generally in the market. Like in calendar method, we just tell the patients about the fertile period, and the patient can then calculate the dates, and in this way, by using the calendar, she can use this method as a contraception. Other method is ovulation method. There are certain strips available in which in certain days in which there is a chance of ovulation, patient can check whether ovulation has taken place or not. Thermal is also a method in which she can check the basal body temperature and decide and assess whether this is the suitable time of coitus or not. Then there are certain methods like hormone monitoring as well. So all these are the methods which do not involve the specific use of any contraception. We have barrier methods, and the barrier methods is not only confined to the male condom, which is very common. There are female condoms as well, diaphragms available, cervical cap and sponges and spermicides, but the commonly used method is that of the male condom. As far as other methods are concerned, usually the patient has to go toward the gynecologist to use those methods for her, so those are not very suitable for her. Among the hormonal methods, we may have certain combined hormonal methods in which the commonly used method is that of the pills, combined oral contraceptive pills. That's all of you know, and it may be of extended. It may be used for extended period, or it may be seasonal. Okay, for a long-term time, it can be used, or for a certain period of time, it can be used. Now, this hormonal method are not only confined to the pills, but we have certain patches as well, which can be applied by the patient, and they release the hormone at specific rate. So, Avra is one of the brand name for combined hormonal patch. And we have Nova ring, that is basically combined hormonal ring, which is used by the patient intravaginally. Apart from the combined pill, we have progesterone only pill. We have the LARC method, okay, long-acting reversible method, which may be hormonal or non-hormonal. Okay, so this table just give an overview about what type of contraceptive methods are available to us. Now let us talk a little bit about the barrier method. As I have told you that the male condom is the most widely used barrier method, and although it is made up of latex, it is cheap and widely available, and not much side effects. But the thing is that it is not favorable and not acceptable for most of the male. Okay, and another important thing is that if the patient has got latex allergy, there is another type of condom which is made up of polyurethane that is also available. Now there is a specific spermicidal agent which is used in the male condom, and that is nonaxanol 9. It is also asked in MCQs that which type of spermicidal agent is used in the barrier method like male condom. That is nonaxanol 9, but the disadvantage of this spermicidal agent is that when it is used frequently, it increases the risk of HIV transmission. As far as the female condoms are concerned, they are usually made up of polyurethane sheath, and there are no spermicidal lubricant present in the female condom, and it can be used only once, and these are expensive as compared to male condom. We studied that the male condoms are cheap, but female condoms are expensive. Diaphragm and caps are less popular, and they need insertion by the doctor, and there is the chance of recurrent vaginal infection, and that is a very common side effect of diaphragm and cap. Means the doctor need to insert this diaphragm and cap. That is why it is not acceptable by most of the patient. Now let us discuss the combined oral contraceptive pills. Mechanism of action is very important. The main mechanism of action is it works at the level of ovaries, and it inhibits the ovulation. Okay, so at the level of the ovaries, it inhibits ovulation. At the level of endometrium, it makes the endometrium atrophic, and in this way it prevents implantation. Okay, and it also increases the thickness of the cervical mucus and inhibits sperm transport. So you can see that it works at 3 levels: at the ovary level, at the endometrium level, and at the cervical level. So that is the main mechanism of action of COCPs. Now this chart shows the different contraceptive methods and their sites of actions. Like you can see, all contraceptives mainly act on ovaries, although they also act on the cervix and endometrium, but mainly act on the ovary. Okay, barrier devices acts at the vagina and cervical level. Okay, and okay, so you can see IUCD here. IUCD works at the intrauterine cavity level. Now, what are the side effects of COCPs? Okay, whenever you prescribe COCP to the patient, the very important thing that you have to keep in the mind is that of the risk of venous thromboembolism. Okay, so the most common and serious risk of COCP is that of venous thromboembolism, and the highest risk is in the first year of use, and the risk is twice in user as compared to those who do not use this method. Okay, so these are the things which we need to consider, which we need to think about while prescribing COCPs. Okay, the second thing is about increased risk of MI, stroke, breast cancer, cervical cancer. And another thing is that whenever a patient is having factor 5 latent mutation, then she has about 20% increased risk of VTE. Okay, and important thing which we need to consider is that the risk of thromboembolism depends upon the type of progesterone used. Like when you use the 3rd and 4th generation, they have higher risk as compared to 2nd generation. And I will tell you the list of different generations of progesterone in the coming slides, but the desogestrel and drospirenone are among the 3rd and 4th generation. Levonorgestrel is the 2nd generation. Okay, and arterial thrombosis, if we talk about arterial thrombosis, then that depends upon the level of estrogen. Means if we have more than 50 microgram ethinyl estradiol, then there is increased risk of the arterial thrombosis. Okay, a progesterone risk is higher in the venous thrombosis. And when we have higher estrogen level of more than 50 microgram, there is higher risk of arterial thrombosis. Now, COCPs are not only used for contraception, but there are certain non-contraceptive benefits of COCPs as well. This question is also asked in Vivas, and all of us should know this. Okay, it decreases the menstrual blood loss and menstrual pain. Secondly, there is a growing incidence of ovarian cyst and benign tumors among the different women. But those women who have used combined oral contraceptive pills, they are found to have decreased risk as compared to those who do not use it. Okay, and third is that the benign breast disease, PID, and acne risk is also reduced, and there is a reduction in ovarian and endometrial cancer to about 50%. Okay, and we should also know about what are the contraindications. The contraindications include women with a breast cancer, raised blood pressure, depression, diabetes, liver, or renal failure. Now, let us discuss these two boxes, although it's a very exhaustive list. But the thing is that several questions in exam come related to these contraindications. The category 3, you can make category 3 criterias and category 4 criterias. Okay, so when we talk about category 3, risk generally outweigh benefit. So that is the main heading of it. And the list include the patient who is breastfeeding between 6 weeks and 6 months postpartum, okay, and fully or almost fully breastfeeding. When you compare it with the category 4, you will come across breastfeeding of less than 6 weeks. Okay, so if we have less than 6 weeks breastfeeding, that is category 4. If between 6 weeks and 6 months, that is category 3. Next is about postpartum period, means less than 21 days time is included among the category 3. Okay, so if patient is at 10 day, 13 day, means lesser than 21 days, and that is written in scenario and categories are, so you will select the category 3. Okay, and nothing is written about category 4 because that is category 3. Okay, so let us discuss the next point, that is the smoking, and compare both. Okay, so in order to memorize this table, the main method is that you just compare each and every point with each other. Okay, so we discussed breastfeeding, compared breastfeeding. Next, we will compare the smoking status. Okay, about smoking, it's written that if the patient is having age more than 35 and smoking less than 15 cigarettes per day, okay, or stop smoking less than 1 year ago, less than 15 cigarettes per day and stop less than 1 year ago. But as far as the category 4 is concerned, patient age is more than 35 and smoking more than 15 cigarettes per day. Okay, and about category 3, we will also say that obesity, BMI of more than 35 kg per meter square, that is included in the category 3, and nothing about weight is written in category 4. Okay, so forget about category 4 regarding the obesity. Obesity more than 35 is included in category 3. Okay, now cardiovascular disease, we can compare both. Okay, cardiovascular disease, multiple risk factors for arterial cardiovascular disease, so that is category 3, and in category 4 it is written that multiple risk factor for arterial and cardiovascular disease. And what are those risk factors? Those are written here. First of all, the hypertension. Okay, hypertension, when we talk about category 3, elevated blood pressure of more than 140 to 159 millimeter mercury systole or 90 to 94 millimeter mercury diastole also adequately control hypertension. So if we have adequately control hypertension, not severe type, that is category 3. But if we have hypertension of severe type, that is more than 160 millimeter of mercury systolic or more than 95 millimeter of mercury diastolic or vascular disease, that is included in category 4. So we did comparison up to this point. After that, hypertension point, we have different risk factors in category 3 and 4, so it's better to study those isolatedly. Okay, so in category 3, we have family history of venous thromboembolism in first degree relative of less than 45 years. Or immobility unrelated to surgery, for example, wheelchair use or debilitating illness. Here a little bit comparison can be done. In category 4, it's written that major surgery with prolonged immobilization. So in category 3, immobility unrelated to surgery. In category 4, we have major surgery with prolonged immobilization. Moreover, in category 3, we have known hyperlipidemia, for example, familial hypercholesterolemia, and migraine without aura at any age, and continuation of method. When we compare it with the category 4, we have migraine headache with aura. In category 3, migraine without aura. In category 4, migraine headache with aura. Category 3, migraine without aura or past history more than 5 years ago of migraine with aura at any age. In category 3, we have undiagnosed breast mass, initiation of the method. And in category 4, we have breast disease, current breast cancer. In category 3, we have diabetes with a nephropathy, retinopathy, neuropathy, or other vascular disease. In category 4, we have diabetes with a nephropathy, retinopathy, neuropathy, or other vascular disease. In category 3, we have the gallbladder disease, symptomatic, medically treated or current, and nothing to mention in category 4 about the gallbladder disease. About the liver disease, it's written that in category 3, we may have patient with a history of cholestasis, past COC related, or viral hepatitis acute or flare. But in category 4, viral hepatitis active or flare, or cirrhosis, severe decompensated disease, or liver tumor, benign hepatocellular adenoma, or malignant hepatoma. And if the patient is having HIV on ART, then she is included in the category 3. So HIV for category 3 and SLE, positive or unknown antiphospholipid antibodies, for category 4. In category 3, we also have drugs which induces enzyme like rifampicin, rifabutane, retinoware, St. John wort, certain anticonvulsant like phenytoin, carbamazepine, barbiturate, primidone, topiramate, oxacarbazine, and lamotrigine. Okay, so if you give a little bit time to these two charts, your life will become easier because several questions come related to these charts as well. Now let us talk about the progesterone containing contraception. Okay, when we talk about the mechanism of action of progesterone only pill, the thing is that only third generation progesterone like desogestrel prevent ovulation. Almost other types of progesterone, they just make cervical mucus thick. Okay, other type of POP makes cervical mucus thick. So that is the mechanism of action. Now, different generation of progesterone is very important to be known by every gynecologist. Okay, the first generation progesterone include norethistérone, lanestreinol, ethanodione diacetate, and norethistérone. The second generation includes levonorgestrel and norgastrel. Third generation includes desogestrel, gastadine, and norgastadine. The progesterone only injectables, they prevent ovulation. Implanon also releases progesterone, okay, and the rate of release initially is 60 to 70 microgram per day, and it falls gradually to 25 to 30 microgram per day. This is also very important. Initially 60 to 70 microgram per day, later on 25 to 30 microgram per day. Now let us have a little bit discussion about intrauterine contraceptive devices. And I have taken the references from TOG article, September 2020. Now, copper IUCD prevents fertilization by creating hostile environments for sperm inside uterine cavity, and in this way it prevents fertilization. Okay, and levonorgestrel prevents fertilization as it acts on endometrium. Levonorgestrel prevents implantation. That is the main difference between copper IUCD. Copper IUCD prevents fertilization as well as implantation, and levonorgestrel basically prevents implantation. Now, in this TOG article, we have different branded products of intrauterine system, levonorgestrel intrauterine system basically. So, first of all, the most commonly used is that of Mirena, which is a 52 milligram levonorgestrel containing intrauterine system, and it is licensed for 5 years for contraception and 4 years for endometrial production. Okay, so the dose is important, 52 milligram, and for how long we will use it. When we use it for contraception, we will use it for 5 years, and for HMB purpose, we use it for 4 years. Okay, so that year is important. And Jadis, that is actually 13.5 milligram levonorgestrel used for 3 years. Kylena, 19.5 milligram levonorgestrel, and it is used for 5 years. Levocert, like Mirena, it contains 52 milligram levonorgestrel, and it is used for 6 years for contraception and 5 years for HMB. Okay, so although the dose is same as we see in Mirena in Levocert, but it is used for longer period as compared to Mirena. And let us talk about copper containing intrauterine system. There are many types of copper IUDs which falls into different categories like banded copper arms and copper T380A. And we have copper stem, Nova T380, frameless, Gynafix. So these are certain intrauterine contraceptives in the clinical practice, and here the durations and the uses are written, like Mirena for 4 year for contraception, 5 year for contraception, 4 year for endometrial protection, Levocert 6 years for contraception, 5 years for HMB, Jadis used for 3 years for contraception, Kylina used for 5 years for contraception. So only Mirena and Levocert can be used for HMB as well as contraception purpose. Now, when we talk about the banded copper arms, we have different types like copper T380 used for 10 years for contraception, TT380 slimline 10 years for contraception, T-Safe 388 10 years for contraception, and copper stem contain the type like Nova T380 used for 5 years for contraception. We have frameless copper IUCD like Gynafix, which is used for 5 years for contraception. This table is basically from TOG article about intrauterine devices, September 2020. Now, what are the side effects of copper IUCD or other IUCDs? Not only copper, we are talking about IUCDs in general. Okay, they may cause heavy menstrual bleeding, intermenstrual bleeding, dysmenorrhea. But yes, when we talk about the levonorgestrone intrauterine system, it doesn't cause heavy menstrual bleeding. That is basically used for HMB. But that can cause intermenstrual bleeding or dysmenorrhea. Now, let us talk about emergency contraception. Several questions in exam come related to emergency contraception. When can emergency contraception be provided to the patient? Emergency contraception should be offered to any woman with unprotected sexual intercourse of less than 120 hours ago, at any time during her cycle, or after 21 days postpartum, or after 5 days post termination of pregnancy, either induced or spontaneous. Okay, so here the overall picture of use of emergency contraception is written. Means maximally it is used for up to 120 days. And it can be used at any time during the her menstrual cycle. But if the patient is postpartum, then it should be after 21 days, means after 3 weeks. But if she had abortion induced or spontaneous, in that case, after 5 days she can use. Okay, so these days are important to remember for exam. Now, this chart is very important for advice regarding the contraception. Okay, if the patient had one pill missed more than 24 hours and up to 48 hours late, then she will have to continue contraceptive cover. The missed pill should be taken as soon as possible, as soon as it is remembered. The remaining pills should be continued at the usual time. So by missing one pill, that is not a big problem. What to do in order to minimize the risk of pregnancy? Emergency contraception is not usually required, but may need to be considered if the pills have been missed earlier in the pack or in the last week of previous pack. Okay, so if there is a scenario in exam that patient just missed one pill, so you will not prescribe the emergency contraception. You will just say that continue the pill. But if she missed the pill in the start of the packet or in the last week, then in that case we will prescribe the emergency contraception. But the problem arises when she misses 2 or more pills more than 48 hours late. Then we will tell the patient to take the most recent pill as soon as possible. The remaining pill should be continued at the usual time. Meanwhile, we will also ask the patient to use condom or avoid the sex for until 7 consecutive active pills have been taken. So this 7 is also important. Sometimes questions come related to this point as well, that for how many days will she avoid the sex or use condom. Okay. Now, in order to minimize the risk of pregnancy, if pills are missed in the first week, emergency contraception should be considered. Okay, if pills are missed in the 8 to 14 days, means in the second week, then no need to take emergency contraception if the pills in the previous 7 days have been taken consistently. And if the 2 pills are missed in the last week, we will ask the patient to omit pill-free interval, means after taking 21 days tablets of COCP, she has to take another tablet straight away and discard the placebo tablets. Now, FSRH guideline shows something about the method of emergency contraception. What method of EC should be offered to women who has had unprotected sexual intercourse and wishes to avoid pregnancy? All the women requiring EC should be offered copper IUCD. So copper IUCD is the most effective methods, okay? But it's very important that it can be inserted up to 5 days, okay? But the thing is written that usually the women do not accept this copper IUCD. It is not acceptable for most of the women. So in that case, the oral EC tablets are taken. If she had OPC 96 to 126 hours ago, she can take ulipristal acetate. And another important point is that EC administered after ovulation is also ineffective. Now, this table shows the different methods of emergency contraception like copper IUCD. What is the mechanism of action? It is toxic to the sperm and ovocyte, and endometrial effect may prevent implantation. Basically, it prevents implantation. Okay, and time after OPC 120 hours. Also, the ulipristal acetate can be used after within 120 hours. Okay, but as far as the levonorgestrel is concerned, that can be used up to 72 hours. Okay, so mechanism of action of these pills are they both prevent the ovulation, and the most effective is that of the copper IUCD. Pregnancy rate in copper IUCD is 1 in 1,000, and ulipristal 1 to 2% pregnancy rate. In levonorgestrel 2 to 3% pregnancy rate. Ulipristal 1 to 2%. So the most effective is copper IUCD. Next is ulipristal, and third one is that of the levonorgestrel. Now the question arises, okay, that we are not giving copper IUCD, so what to choose between these two pills, that ulipristal acetate or levonorgestrel? Okay, the questions in exam MCQs questions come related to this point as well, that you are given both options, so what you will choose. Ulipristal acetate has been demonstrated to be most effective than levonorgestrel from 0 to 120 hours after OPC. And it is important to bear in mind that the evidence suggests that both are ineffective if taken after ovulation. But the main problem is when OPC takes between 96 to 120 hours, means after 96 hours, if the patient comes with the history of OPC, then in that case levonorgestrel is ineffective if taken more than 96 hours. So in that case the ulipristal acetate is more effective. And is there any effect of BMI on emergency contraception? It is written that the effectiveness of levonorgestrel could be reduced if woman has BMI of more than 26 kg per meter square or more than 70 kg weight. So in that case, if an MCQ that much weight is written, more than 70 kg or BMI of more than 26, so in that case if the dose of levonorgestrel is written, then we will prescribe the higher dose of levonorgestrel. Either we have to prescribe the ulipristal acetate, which is more effective as compared to levonorgestrel, but if the dose of 3 milligram or double the dose of levonorgestrel is written, we will go for that option. Now, the effect of enzyme inducing drug, if the patient is already taking enzyme inducing drug, then in that case it's written in guideline that we need to prescribe the double dose of levonorgestrel, but still there are not much evidences about its effectiveness. This table is from FSRH, and I have mostly explained all these methods with you, and also the doses and the time periods within which it can be used. Again, this chart tells you that for how much time is each and every method effective. Copper IUCD up to 128 hours after intercourse, levonorgestrel up to 72 hours or 3 days after intercourse. Sometime it may be used up to 96, or ulipristal up to 120 hours after intercourse. Okay, now this is from FSRH that can be prescribed the oral EC if there has been OPC in the earlier in the cycle. About this, it's written that both these methods like ulipristal and levonorgestrel can be used if OPC took place in the start of the cycle or within the last 5 days. Okay, because evidence suggests that even if pregnancy takes place, these two methods do not disrupt an existing pregnancy and are not associated with the fetal abnormality. That is usually the patient question, that if I take emergency contraception and they do not prove to be effective, so will that affect my future baby? So we can tell that there is no evidence that these drugs can affect the fetus. And another question, can oral EC be taken more than once in a cycle? Yes, if it's written that yes, she can take EC pills more than once in a cycle, but the thing is that they should not be taken in the following 5 days of the previous dose. They are proved to be less effective if taken in the following 7 days. So after 7 days of the previous dose, she can take another dose if required. That is the missed pill protocol. It's almost the same as I discussed with you previously, that if 2 or more pills are missed, take the last missed pill, continue the rest of the pill as usual, use condom or avoid sex for 7 days. And if pills are missed in the 1 to 7 days, give EC. And if pills are missed in the second week, no EC pills. And if pills are missed in the last week, omit pill-free interval. Now, this chart from FSRH guideline about emergency contraception is very important, that if the patient is currently less than 1 to 20 hours since the last OPC, yes, then additional OPC this cycle more than 122 hours ago. If that is the case, we will follow this algorithm. But if that is not the case, means there is not currently less than 122 hours since the last OPC, means more than 122 hours after last OPC, then we will see whether she had currently less than 5 days after earliest likely date of ovulation. And then we will follow this algorithm. But if patients say, I don't know whether 122 hours have passed or not, so that situation is unknown. So we will see whether currently she is less than 5 days after earlier likely date of ovulation or not. Then in that case, we will follow this algorithm. Okay, so in each and every step, you have to understand in which direction we are going on. Okay, so let us start from here, that yes, there are less than 122 hours since the last OPC. And we asked the patient whether she had additional unprotected intercourse as well, more than 122 hours or not. If she say no, she didn't have any additional unprotected sexual intercourse, then you can offer her a copper IUCD, because this is very effective. But if she says that this is not acceptable to me, then offer oral emergency contraception and a suitable ongoing contraception. Okay, but let us go back. Okay, if the patient says that yes, currently she is less than 122 hours since the last unprotected sexual intercourse, but she had additional unprotected sexual intercourse in this cycle about more than 120 hours ago, if that is yes or unknown, we will check currently what is her likely ovulation date. If currently she is having less than 5 days after earliest likely date of ovulation, then in that case we have to offer copper IUCD. If not acceptable, then oral. Is we have to offer the emergency contraception. If that is unknown whether she is having currently less than 5 days after earliest likely date of ovulation, then in that case we have to consider pregnancy test if OPC in this cycle more than 21 days ago. And after that, we will offer oral emergency contraception and suitable ongoing contraception. Now coming to the middle part, currently she is less than 5 days after earliest likely day of ovulation. Then in that case, offer copper ICD, because oral EC will not be effective. But if we don't know, and if it is not known, or if it is not the case that she is in the less than 5 days likely date of ovulation, then in that case, prescribe oral EC, unlikely to be effective. Okay. Sorry, don't prescribe oral EC. Oral EC unlikely to be effective. Offer suitable, quickest contraception method like copper IUCD. Let's come to the third point. When she is unaware whether she currently had less than 122 or since the last biopsy, then we will check whether currently she had less than 5 days after earliest likely date of ovulation. If yes, then copper IUCD. If not acceptable, offer oral EC and suitable ongoing contraception. If no or unknown, offer oral EC and suitable ongoing contraception. This is also a decision making algorithm, and the things are almost the same, which I have explained to you in the previous chart. BMI is also written, and it's written that we need to give the double dose in case of the raised BMI. Here in this chart also almost the same things are written. Woman requesting EC, we will offer IUCD because it's very effective. If it is refused by the patient, then we will go for levonorgestrel or ulipristal depending upon the time period. And there's certain contraindication of ulipristal like hepatic impairment, asthma, and patient originally on progesterone containing method but missed. Now the exam question, 22 years old girl had 28 days regular cycle. She attended gynae clinic on the 20th day of the cycle due to content break, and she took levonorgestrel 13 days back and had unprotected intercourse, and she then was using condoms, and she is worried and asked for contraception. What would you advise? So advice is copper T because Levonorgestrel will delay her ovulation. Now coming to sterilization, different methods are shown here. We have mini laparotomy, laparoscopic, and hysteroscopic methods of sterilization shown here. That is the comparison of different methods of sterilization. The highest success rate is that of the Irving. Highest failure is that of femrectomy, 2 to 3%. Medliner failure rate is 0.6%. Pomeroy method has failure rate of 0.3%. Most effective method is female sterilization. Female sterilization is that of Irving. Now, another topic in this FSRH guideline about sterilization is that when should vasectomy be considered as failure? Okay, several questions come related to this point as well, and the main point is that if motile sperms are observed in the fresh sample 7 months post procedure, the vasectomy is considered as failure. Now the Pearl indexes are shown in this table. Number of unintended pregnancy divided by number of women using any method of contraception. This is from the latest TOG article, September 20. UELE, the students memorize this table from the 10 teacher 20th edition, but that was taken from the old guideline, and this is the new. And while looking at this table and taking the screenshot, you can solve exam questions related to the Pearl index. Okay, the most successful method is that of the implant, and its effectiveness is that, or the number of unintended pregnancy is 0.05. Lactational amenorrhea, a woman who is fully breastfeeding and amenorrhea during the first 6 months after childbirth has a 2% chance of getting pregnant, so it is 98% effective. Okay, if it is used in the first 6 months, there is 2% chance of getting pregnant. Now the choices of contraception after birth is shown in these two charts. You can see that IUCD can be used up to 48 hours or after 4 weeks. Female sterilization up to almost 1 week or after 6 weeks. And male sterilization can be used throughout the time, and also the condom spermicidal agent. And emergency contraception after 4 weeks, diaphragm after 6 weeks, lactational amenorrhea up to 6 months, and progesterone only pills prescribed after 6 weeks, and combined estrogen and progesterone after 6 months, and progesterone only methods like POP in case of the non-breastfeeding woman can be prescribed straight away after birth, and combined estrogen progesterone in non-breastfeeding women can be prescribed after 6 weeks and 3 weeks, and in case of the breastfeeding woman, it should be prescribed after 6 months. Okay, so there are certain points like IUCD can be safely inserted immediately after birth within the 10 minutes of delivery of placenta, or within the first 48 hours after uncomplicated cesarean section or vaginal birth. After 48 hours, insertions should be delayed until 28 days after childbirth. Implant can be started at any time after childbirth. So these are different methods. Progesterone only injectable can be started at any time after childbirth, including immediately after delivery. And as far as pills are concerned, these can be started at any time after childbirth, including immediately after delivery. And combined oral contraceptive pills. All women should undergo risk assessment for VTE postnatally. Combined hormonal contraception should not be used by the women who have risk factors for venous thromboembolism, VTE within the 6 weeks of the childbirth, and these include immobility, transfusion at delivery, body mass index of more than 30 kg per meter square, postpartum hemorrhage, and post-cesarean delivery, preeclampsia or smoking. And this appears to be both women who are breastfeeding and not breastfeeding, women who are not breastfeeding and or without additional risk factors for VTE should wait until 21 days after childbirth before initiating combined hormonal contraceptive methods. Okay, thank you so much for your kind listening. Although there was a lot of information in those TOG articles and FSRH guidelines, but I have tried my best to collect the important points.